Thank you, Neil. Thank you. I'd like to thank the organizers, especially Dr. Ravi Tandon, an old friend with whom I worked as a postdoc in the US for a couple of years. And now I get the chance to finally virtually come to India, since I still haven't had the chance to come in person. Hopefully in a better moment, we'll get the chance to interact in person. And in the meantime, I'd like to share with everyone a little bit of our experience during the pandemic, because as Neil mentioned, we are the new, unfortunately, epicenter of the pandemic at the moment in the world. So I'd like to share my screen, but it doesn't look like it's possible at the moment. Can please someone enable that?
Hello? Fabio, you can use the share screen.
I can't. It's host disabled attendee screen sharing. So maybe I heard something about turning me into a co-host while I share my screen, so I can do that. I'm not sure. Oh, okay. Now it's working. Now it's working. All right.
Yeah, we can see.
Okay. Well, I think the first step is to show a little bit of where we stand. I will basically be talking about the community-based approach to the pandemic that we were able to set up in São Caetano do Sul, which is a city in the greater São Paulo area. I will briefly show to everyone where this is located. But before that, I'd like to, just one second, because I want to put that in the presentation mode. Here we go. All right, so this is this screenshot from Johns Hopkins University, the Coronavirus Resource Center, showing that, unfortunately, as of yesterday, Brazil is not only the second country in number of cases with almost 1 million cases, but also the second one in the number of deaths with more than 41,000 cases. Brazil has a population of around 210 million people. So that also represents, that has to be put into context, into perspective. But like I heard in a previous talk about the importance, this is a little off the topic from what I will be talking, but I think this is critical, and I'd like to share this experience and this view with you that we have in Brazil, is that this pandemic for countries like Brazil, India, United States, like with large territories, it does not behave as one single entity. We cannot consider the pandemic from a national perspective as being in one time point. We noticed that here we had peaks and we had different epidemiological situations over time since March that were very distinctive from north to south. And Sao Paulo and Rio, the largest urban conglomerates, were precisely the epicenters of the pandemic. So apparently the areas where we have the higher density of population, these are the areas that will suffer more and that will have a huge impact of the pandemic, and they need specific strategies to handle the pandemic, and with different time points compared to the countryside or other rural and smaller urban areas. So I think that would apply to India as well, because I started to pay more attention to the India numbers, and apparently India is not that far from the path that Brazil unfortunately followed, and that I hope that India will learn from our mistakes, unlike we did with Europe and United States, because we had the chance to see what did not go well there. And from a national perspective, it never happened here, the adjustments that were needed, precisely because this is a personal view that I'd like to share with all of you before I start talking about our data, precisely because we did not have, and we still don't have, a national efficient coordination of all strategies, because different areas in the country would need different synchronized strategies that would be obviously managed by local administration, because they know the local population better than the national government, but this has to be a coordinated effort, and the political issues have to be resolved outside the public healthcare and the science aspects. And unfortunately, there's a lot of interference, and it has led basically ultimately to the situation that we have here. But locally, we have tried to do some different strategies. So just to show you where we are and where we are located, I think it would be interesting to just spot the city that I'm talking about and where I am right now, that is called São Caetano do Sul. So there are 37 municipalities in this urban conglomerate that you see now. This is the greater São Paulo. Over 20 million people live here. And São Caetano is a city with 15 square kilometers. So it's very small compared to the total area, but with a very high populational density. We have 160,000 people, so it's 11,000 people per square kilometer. So this is the whole urban area, and this is where we are situated in the country. So we are in the southeastern area of Brazil. And this is actually, together with Rio, so far the epicenter of the epidemic, with representative of the largest number of cases in the country. So here we are. This is Brazil for those who are not so familiar with the dimension and the proportion of South America. So basically Brazil, from a population perspective as well from an area perspective, represents around 50% of South America. Well, one thing that could give us a good advantage and a good start dealing with the pandemic is the fact that Brazil has a national health system called SUS that is a universal free healthcare that provides primary, secondary, and tertiary care to all Brazilians, and it's spread by basically all municipalities. So every city, every village in Brazil has at least a healthcare unit that provides healthcare free of charge to the population, with a multi-professional team on these units. And it's funded by a combination of federal, state, and municipal funds. And it works reasonably well, especially for primary care. And whenever secondary or tertiary care is needed, patients are referred from these healthcare units to different types of hospitals in the area. So we just thought that it would be an interesting approach to take advantage of this structure and establish a strategy that would be focused on public health care and primary care, so we could address the epidemic in the community. Because like it was said in the previous talk, the numbers are very underestimated, because as well as everywhere else in Brazil, the national numbers, the general numbers, are showing basically the number of cases that are admitted to hospitals or the number of deaths. So we actually don't know how the pandemic is behaving in the community and what the real numbers are. And we only have a blurred picture of what happened a couple of weeks ago when we look to numbers of admitted patients and deaths. Well, but one specific aspect that made us worry about São Caetano do Sul is the fact that the aging index of our population in the city is way higher than the rest of the country. So if you see the state of São Paulo, which is the region where São Caetano is, we have 41 million people in the state, and the aging index is basically the number of people over 60 years of age divided by 100 people that, in that area that are under 15 years of age. So the Brazilian index is around 49, and we have approximately 14 to 30% of our population over 60 years old. São Caetano instead has an aging index of 125, because we have more than 20% of our population over the age of 60 years. So that caused a major concern, because within the epicenter of the pandemic, São Caetano could be the worst place among all 37 cities that are in the area, because as you can see, they are all less than half the aging index. So to simplify what our strategy was, we basically started a partnership with the University of São Paulo and the City Hall, because I'm part of the University of São Caetano, to put together an innovative strategy using a website-based initiative. So patients, anyone living in São Caetano with symptoms could register in this platform or call a 1-800 number, and they would answer questions. They would put personal data and also answer questions regarding symptoms. And if they had a score, they would be selected to go to a waiting list and wait for clinical assessment by telephone by one of our 5th or 6th year medical students that were properly trained. If that score was confirmed and more information about comorbidities and signs of severe disease would be addressed during the call, these patients would receive a home visit, which is part of the whole primary care strategy in Brazil. And we would just include that in our strategy and take advantage of it. And another medical student would go to that patient's place to do physical examination and also provide with a kit for self-collected swabs. So these patients could collect PCR and would receive the result from the labs from University of São Paulo after 3 days through the same medical student who would be responsible and supervised all the time by the team from University of São Caetano, the professors, to do clinical follow-up every 48 hours for 14 days of those patients that are PCR positive, that were PCR positive. The ones that are PCR negative after 14 days would receive a serology test to make sure that we were not missing cases because of false negative in PCRs, which is actually a good point and actually a real issue when dealing with the pandemic. But more than that, this is not part of our strategy. This is just a flow chart of the strategy that we put together. The city provided other strategies like mass testing with serologies. So we actually have a population of 160,000 people. And so far we tested 20,000 people and we keep testing over time. The major issue is precisely how sensitive and how specific these tests are. And we noticed that there is a great variation of sensitivity depending on the test. So we actually did the validation in our labs to make sure that we are dealing with high sensitivity when we are doing serology. And the next step I will mention in the end of this presentation to actually be able to control the pandemic is one that we still haven't been able to combine with the current strategy, which is contact tracing. But anyway, during the clinical assessment, we would get symptoms and signs, the common symptoms of disease and comorbidities. And so far, what we have found, what we have been able to do since April 6th is to see more than 6,000 patients. So maybe around 6,000 patients actually were selected because they had a positive score, they were symptomatic. And over 4,000 home visits were done to collect samples and do clinical assessment. And from all these patients in the last 2 months, we have more than 1,000 positive cases by PCR and more than in around 100 cases for serology from those that were PCR negative. And this is a little bit of how the epidemic has behaved in the community from a symptomatic perspective. Again, we're not talking about pre-symptomatic or asymptomatic patients, but as you can see, in the last month, we reached an average of 25 to 30 cases. The red columns are positive cases. The blue columns are the number of total tests that were done. And the black line is basically the percentage of positive cases out of all tests that were done that day. So we basically have around 25 to 30 cases across the last month every day. And this is not showing any sign of reduction. And this is something that we realized recently, that we basically reached a plateau, which is a very uncomfortable situation. It looks like our RT is around 1, and it's fluctuating around 1, keeping the epidemic in a stable condition, but again, with a significant number of cases. And just as a general information that is outside our strategy, we have so far 67 deaths in the city considering the characteristics of our population and the fact that we are in the epicenter of the pandemic in Brazil, these numbers are relatively low compared to the cities that are around São Caetano. So that would represent around 40 cases, 40 deaths per 100,000 people. What we did from a scientific perspective was to select a specific period of follow-up. So we got April 13th to May 13th, and do a more detailed analysis of our data. So this is actually data that will be published next week, and that we've been working intensely to do the initial analysis of our strategy. So from April 13th to May 13th, we saw 2,600 patients, and more than 1,500 PCRs were performed. Out of these 1,500, 444 tested positive, and around 1,100 were negative. And we had a very low number of inconclusive PCR tests. The PCR negative patients were offered the serology tests, and only half of them actually showed up to do the serology test. And we detected 52 out of around 600 patients that were tested by serology that were also positive. So these were supposedly the cases that we missed by a false negative PCR. This is the figure that is similar to what I showed before. The one before was more up to date than this one. And this is a little bit of the age distribution and proportion of what we've seen. Apologies for the picture that is a little blurred. But what we can see here is that patients undergoing PCR testing are mostly patients in working age, and specifically females, more than the population, the proportion of the population in the city. So the blue columns are the population, the pink here, patients undergoing PCR treatment. And when we look at the results, again, PCR positive patients are overrepresented in the population between 30 to 50 years of age, especially even more among male patients. When we look at the baseline characteristics of our population, São Caetano has a very distinct characteristic compared to the rest of the country, because again, it's in the wealthiest area and the most urban and more dense area of the country. So it looks more a little bit like cities in Europe, with an older population and with a high level of education. But again, this data is interesting because when we look at the level of university degree for the PCR negative patients, it's significantly higher than patients that were PCR positive, showing the social economic difference that also is combined with educational level across all populations, regardless of being in a wealthy area or not. And when we look at the presenting symptoms among the patients, what we see is one initial interesting finding is that a sore throat is actually not a good sign to suspect COVID-19. So we're not saying that this is an uncommon symptom. So as you can see, the blue dots, the dark blue dots are PCR positive, the light blue dots are seropositive and PCR negatives, and the lines are basically the confidence interval, 95% confidence interval. So we can see that around 50% of our patients that were positive had a sore throat, but it was way more common among seronegative patients. So this is actually not a good symptom to distinguish these patients, unlike loss of taste. Loss of taste, indeed, because the data that we have so far in the world are mostly based on hospital admitted patients, more severe cases. So this is to show that some of this data has actually been confirmed in the community, and mostly mild to moderate cases, because that's the majority of the cases that we are seeing. So far we had only 30 patients that were hospitalized among more than 1,100 patients that were positive, and only 3 cases of death. Another symptom that showed to be very distinctive is anosmia. So loss of smell is very differently presented as part of the syndrome to patients who are positive compared to PCR negative, seronegative. And the next one that is very interesting is fever. So fever is very distinctive of patients who are probably PCR positive. So whenever the patient is not febrile, it's very unlikely a PCR positive patient. It does not mean necessarily that this will not be a patient with COVID-19, but the PCR will unlikely be positive for this specific patient. So fever is an important symptom to be considered. And another one that we found to be significantly different is myalgia. So muscle pain is very common among all the respiratory syndromes, but clearly it's almost universal among the patients who are PCR positive or seropositive. It's around 90% here compared to 70, 65% average for these patients, with a significant difference between these groups. So this is a different way of representing it, basically showing the odds ratio for all these 5 symptoms that I mentioned, showing how they are way more representative of PCR positive and seropositive patients, because this is the combination of these two groups compared to other symptoms, and sore throat being a symptom that is not useful at all to distinguish COVID-19 from other diseases. From a clinical perspective, another aspect that we find interesting for age groups is that the youngest patients present usually with respiratory symptoms way more often than the general population. So runny nose, a sore throat, and congestion, nasal congestion are more common among the patients who are under 20 years of age. This is just to confirm the idea that we have that this is the mean CT, so meaning that the highest the CT, the lower the viral load. So basically, these low CTs mean a higher viral load, and we notice that the highest viral loads are among 3 to 5 days of symptoms onset. So this is actually the period when it's more appropriate to collect PCRs. Although something that I'd like to share with you is that since we are following a cohort, we are seeing very unusual cases and people who have prolonged symptomatic disease with PCR positivity, and that's another thing that we're going to be publishing shortly, and with viable virus in samples up to 37 days after symptom onset. So even though this is the average and the general idea, there are many outliers, and these patients are important and there should be a focus on these patients because they could be spreading the virus for a prolonged period. It's very marginal, the difference, but also we noticed that the time between symptom onset and swab collection was significantly shorter among PCR positive patients than seropositive patients. So those who collected it earlier were more likely to have a PCR positive. And this is just another way to show the time between symptom onset and swab collection, showing that when it was collected among 3 to 5 days, there was a higher chance of PCR positive, and PCR in serology was positive even over time, almost getting to 10 days after symptom onset. Well, for patients that were hospitalized, we just found the general idea that we already have about the pandemic, showing that people over 60 years of age, even though the numbers are small, 30 are actually among just the 1,000 patients that we analyzed. They are highly represented among the hospitalized patients compared to the ones that were not hospitalized. And again, the comorbidities, as expected, especially cardiovascular disease. Most of these patients, high blood pressure and diabetes were overrepresented among hospitalized patients compared to not hospitalized. And same thing for obesity. Those that had a body mass index over 35 were significantly more represented than in hospitalized patients than in not hospitalized. But we could only do univariate analysis because the numbers were small. Well, and the next step that we've been trying to combine with this strategy, because we first started with the strategy of finding symptomatic patients, because we know that these are the most important spreading the disease. Unlike we thought in the beginning, the ones that are symptomatic are usually the ones with the highest viral load, and capable of transmitting more efficiently the virus. So we started with those patients, and their contacts will probably be infected as well, because we know that the virus is highly contagious. So these patients should also be addressed regardless of symptoms, because these are very strategic, because they are asymptomatic and they are just circulating, they're moving around and spreading the virus as well. So the focus should be on both symptomatic and asymptomatic, or actually pre-symptomatic patients, as the World Health Organization clarified this week. This is our main goal at this point and for the next step. So we would like to be fast enough to contact the household and work collaborators from these symptomatic cases, isolate them and test them and follow them up. So we would be able to isolate, let's say, depending on the moment of the pandemic, even 10% of the population, and keep them from moving around, reducing the viral spread in the community. But this is still in progress, and I will be glad to share this once we have it up and running. But so far, it is working reasonably well in São Caetano, because despite all the characteristics that I showed of aging population and high density, populational density, we have so far 40 cases per 40 deaths per 100,000, compared to the cities surrounding us that are 2 or 3 times that value. Well, and with that, I would like to thank the opportunity to share with you all the experience that we are having locally in Greater São Paulo, in this urban area, as well as my views from the national situation in Brazil.